Sir, lots of talk is going on the pulmonary artery hypertension. So, what are your thoughts on how prevalent this particular condition in globally as well as in India?
Dr. Inglu, this is a very pertinent question. Of all the diseases that we see as a cardiologist, this is the most frustrating and most debilitating disease that we see. As many as 3 per 10,000 patient population is affected from pulmonary artery hypertension. Normally, pulmonary artery hypertension has got 5 varieties. One is idiopathic, then pulmonary artery hypertension because of left heart disease, or because of lung disease, or chronic persistent thromboembolic phenomena, or unknown factors. But this is very frustrating because the average lifespan of a patient after being diagnosed of pulmonary artery hypertension is only 2.8 years. That is within less than 3 years the patient will be lost. And much more surprising and troubling is in pediatric age group, doctor, this survival is only 8 months. So consider the frustrating aspect. A child has been diagnosed pulmonary artery hypertension and within 1 year he is no more. And surprisingly and interestingly and still challenge to the cardiologist, the medicines and treatment have only improved the quality of life, but they have not been able to prolong the lifespan. The expected lifespan has not improved substantially, while as compared to the patients of myocardial infarction, tuberculosis, hypertension and diabetes mellitus, infected endocarditis, the medicines change the natural history, where the natural history in the terms of longevity is not improved. Maybe with the newer and better medicines, maybe with the newer research, attacking the pulmonary artery hypertension at a different footing altogether, may we be able to prolong the life beyond 3 years, 4 years, 5 years. As of now, is much more dangerous than the cancer. See, the average life expectancy, as I mentioned, is only 2.8 years, nothing.
Right, sir. So, sir, what treatment modalities are available so as to reduce this morbidity and mortality, and is there any new addition to the treatment modalities?
What include, see, a lot of research and development of new molecules is going on. As you are yourself aware, development of a new clinically useful molecule takes 20 to 25 years before it can come to the practice. Earlier we were using PDE5 inhibitors like sildenafil, tenofil for pulmonary hypertension. Calcium channel blockers are also being used. But a new compound has come on the horizon that is known as riociguat. Riociguat is the compound which helps in increasing the presence of cyclic guanosine monophosphate. You will ask me, what is this? In the smooth muscle cells of the bronchial, this compound, cyclic guanosine monophosphate, increasing the vasodilatation. It affects in the smooth muscles, improves the production of nitric oxide, which again improves the vasodilatation. So this particular compound is an ester. This promotes the soluble guanosine enzyme which is present in the smooth muscle cells. So when the soluble enzyme is more, the dilatation is more. It also helps in increasing the sensitivity of the nitrous oxide even at low levels to dilate the bronchioles.
Right, sir. So, sir, according to you, what clinical trial evidences are available for riociguat, and what is the future in India?
See, India is a developing society. A lot of attention is coming on the angioplasty, angiography and all those things, or aortic wall replacement. Unfortunately, we must admit, not much of research is still focused on the pulmonary artery hypertension, but certainly large scale with huge volumes research is required for development of a better and newer molecules.